So I want to talk about a Y-shaped sacral fracture in an elderly patient after a fall. So this is a 68-year-old female. She had a low energy fall in the shower and presented with an isolated injury to her pelvis. She previously ambulated without assisted devices, so she was community ambulator, did not require cane or walker, and she has minimal medical comorbidities. So we're all very healthy. The plain X-rays, you don't see much. I think one thing that's notable, that's common in these patients, you can see the distension in the bowel gas. She's presenting a couple days from her injury, so a lot of times these injuries can get missed or seen at outside places and not treated. And then they can come in with issues with going to the restroom, both urinary retention and issues with constipation. And you can see some of that on our X-ray here. And so we got a CT scan like we do for most of these injuries to help identify the injury. She had pain posteriorly and some in the front. And when you look at her axial CT cuts, here as you come down, you see some arthrosis in her spine, but really, you don't see much, and we'll go back through this in her sacrum. It's hard to see. And then she's got some non-displaced fractures in the front of her ring as well. So as we come back through this, her sacrum, she has bilateral sacral fractures in zone 2, and they're fairly minimally displaced, but she's had some significant pain. You can see them there on that cut. And then as you come to the front of the ring on the left side, she's got minimally displaced fractures of the superior and inferior ramus. And then I think when you look at this sagittal view, that's really telling. Anytime you see bilateral sacral fractures, you want to look for that. And you can see a transverse component here between S1 and S2. And like we talked about earlier with the bowel and bladder, if you look, you can see her bladder in the soft tissue shadow, and it's very full. So it's something we commonly see in these patients with pain. And I think it's really an indication of what's going on, and surgery can help them with stabilization. So we've identified here a Y-shaped pattern. She's got a U-shaped pattern in the back and then extension into the left hemipelvis. And so I've gotten fairly aggressive with these over time if they're having pain and not mobilizing well. I do think stabilization helps them to move. And so for her, we did this supine on an OSI flatbed, and she had a central sacral bump. I think the one other thing that's notable, if we go back on her CT, is we like transsacral transiliac fixation for these because we're really trying to stabilize the central sacral segment and the entire upper body and spine back to bilateral lower extremities. But here she's got some dysmorphism, so there's not really a pathway for a transsacral transiliac screw in the upper sacral segment at S1 above the transverse component. And so, that in the past may be an indication if you're doing surgery, you can just try bilateral SI style screws, but it may also be an indication for lumbopelvic fixation. And so, I would say before we saw this implant that can actually perform in 4 dimensions, you really didn't have a pathway to get all the way across. And so here I started up at the front of her ring just because it was non-displaced and I did want to add stability. My starting point was a little too low, so I just then adjusted the starting point a little bit more cranial and used a more standard 7.3 millimeter screw at the left hemipelvis. And so this was put in first, and then we come to address the back of the ring, and the CurvaFix here allows us to be transiliac transsacral, and you can see us getting the starting point and here using the flexible ball tip guide wire to go across both fractures and be able to do this really. And you've got to think in 4 dimensions here to get across in a transsacral transiliac fashion that I couldn't have done with a standard screw. And there you can see the curve on the outlet imaging. Here you can see the reamer being able to penetrate the other joint in this osteoporotic bone. And you can see us reaming now as we go across. Here we just needed to penetrate the far cortex, so we did temporarily switch to a bigger guide wire from a 7.3 set, but here comes a rod screw coming in. You can see us avoiding both of the foramina and then coming across in a transsacral transiliac fashion. And this would not have been possible with a standard screw. So you can see on these final images with fluoro here, and we'll go over the CTs in a second, you can see that now in this dysmorphic segment at S1 above a transverse component, you can see an outlet image here where we've been able to safely go across that corridor. And you can see an inlet image here. And so, I think this was a real advantage and something I couldn't have done before the CurvaFix. And I think you may have been just trying 2 SI style screws in the upper sacral segment. And then if you had issues, you're looking at lumbopelvic fixation. But I think this was a really nice solution for a problem we couldn't deal with percutaneously before. And so here is her postoperative CT scan. And you'll see on the images here, we were able to navigate this corridor with the rod screw and CurvaFix. And she was neurovascularly intact postoperatively with no issues. And then we had a screw up front. So really, really pleased with the surgical result here and what we were able to do that we wouldn't have been able to do before. And you can see just coming through it again. There's the rod screw starting. We're able to be anterior to each of the foramina. It's a little hard to see with the scatter, but then transsacral, transiliac, and also safe for L4 and L5 behind the anterior aspect of the lateral sacrum on both sides. So really a nice solution for this problem that we didn't have. And she did very well clinically. I made her weight bearing as tolerated with a walker early on. I did not want to restrict her. There's a ton of force on these injuries because you essentially have the entire body, upper body and spine attached to this U-shaped component. I do think she slightly displaced a little bit, and you can see that on the outlet image before we had that arc going up, but clinically she healed without symptoms. And at 3 months, she was walking without pain, had no issues, and was largely back to her prior function. So really, really pleased with the clinical result, and the patient was as well. And I think the take-home points were the rod screw allowed transiliac transsacral fixation in S1 of a dysmorph. And this would not have been something that would have been possible with screws that were straight only. And then there's a ton of force in these U-shaped sacral fractures. So you can see here, even with some stabilization, she might have displaced just slightly. But I think being aggressive earlier on with these fractures, especially when patients aren't mobilizing well, and they often show up to you late, I think stabilizing these is a good thing, especially for these elder patients where mobility is such a key to life. Thank you very much.